Good afternoon, everyone. Presenting Culpepers Curiosity. We are interns from Medicine 4. A 62-year-old postmenopausal lady from Andhra presented with complaints of generalized body aches, which was insidious in onset, involving trunk and limbs, not limited to the joints. She also had anxiety, for which she was referred to MHC for evaluation. So while she was waiting outside the OPD for her appointment, she had a syncope and was sent to casualty, following which she was admitted for further evaluation. So there was no history of fever, no history of vomiting, headache, blurring of vision, no history of seizures, bowel and bladder incontinence, no history of early morning stiffness or rashes or photosensitivity. She had no history of loss of weight or loss of appetite. Past history, she had history of slip and fall from her bed and had a right clavicular fracture in 2022. She had a history of left shoulder adhesive capsulitis in 2023. She had a CBD stricture for which she had a ERCP stent placement in 2020. She is also postmenopausal for 5 years. She had an episode of lower backache in 2022, which was diagnosed as renal colic, and she had history of passing calculus per urethra. Her comorbidities, she is a known diabetic for 10 years on tab metformin 500 mg BD. She is a known hypertensive for 10 years on tab telmisartan 40 mg BD. Known hypothyroidism on tab thyroxine 50 mcg AMOD. She is not on any other medications other than the above. So the syndrome was an elderly postmenopausal lady who had the problems of anemia, pathological fracture, previous history of renal calculi, syncope, which could have been due to maybe arrhythmia, anemia, or metabolic, and also anxiety. So the differentials we considered were could be a neoplastic process, multiple myeloma, chronic kidney disease, or metabolic bone disease. So on general examination, she was conscious, oriented to place, time, and
Tell us
person.
the positive ones, the things you need to highlight.
On general physical examination, pallor was present. Her vitals were stable. Systemic examination was unremarkable. Thyroid and breast was normal. On investigations, her blood profile showed a microcytic hypochromic anemia with retics of 1.2 showing a hypoproliferative marrow. Her iron workups were suggestive of a iron deficiency anemia. Her biochemical tests like liver function test, electrolytes, urea, creat, uric acid, and TSH were normal. She was found to have a calcium of 11.62 and a phosphate of 2.4. So the corrected calcium was 11.94. So the clinical manifestations which we found in her in favor of hypercalcemia, where she had osteopenia, she had frequent fractures, she had history of kidney stones, fatigability, muscle weakness, anxiety, and sleeplessness.
Considering the hypercalcemia, it can be approached as parathyroid mediated and non-parathyroid mediated. So parathyroid mediated involves hyperparathyroidism, which causes activation of osteoclasts and increased bone resorption and elevated intestinal calcium absorption. Chronic kidney disease can also cause the parathyroid hyperplasia. So autonomous parathyroid overproduction, which is also called as the tertiary hyperparathyroidism. The other two rare forms of parathyroid mediated causes were metaphyseal chondrodysplasia, which is a rare form of dwarfism, significant hypercalcemia and hypophosphatemia are seen in these patients, mutation of parathyroid hormone related peptide gene, and familial hypocalciuric hypercalcemia. It is also a rare autosomal dominant disorder. Hypercalcemia and hypercalciuria are seen. Loss of function mutation in the calcium sensing sensor on the parathyroid cells and kidneys. Non-parathyroid mediated involves malignancy, hypervitaminosis D or chronic granulomatous disease, and immobilization. Out of them, malignancy is most common thing. Solid tumors and multiple myeloma and leukemias are the common malignancies which cause hypercalcemia. Bone resorption and osteolysis are the reasons. They release the cytokines IL-1, lymphotoxin, IL-6, HGF, and RANKL, which release the osteoclast factors and thus causing the hypercalcemia. So going on to the evaluation of the hypercalcemia, when we did the calcium, it was 11.71 and corrected calcium came up to 12.03, which was elevated. So we proceeded to doing the parathyroid hormone, which was 113.4, which is also elevated, suggestive of primary hyperparathyroidism. To confirm all the above diagnosis, we did an imaging USG of the neck, which showed possibility of parathyroid adenoma. To confirm the metabolically active state of the parathyroid, we did a scintigraphy, which also showed the tracer accumulation suggestive of parathyroid adenoma left inferior. The other workups for paraproteinemias were also negative. Urine BJP, serum electrophoresis, and 24 hours urine calcium were negative. So finally, we concluded with the diagnosis of primary hyperparathyroidism, parathyroid adenoma. What we did for our patient is first strict input-output charting was done. Normal saline infusion at 150 ml per hour was given. Since there was no improvement, we went on with injection zoledronic acid 4 mg. Routine calcium monitoring was done twice daily. So the calcium by the time we discharged came up to 9.14. So she was discharged and was planned for surgery for parathyroid adenoma. Coming to the topic, just wanted to give a brief definition about the topic. Culpeper is an English physician and a botanist. In 1650, he observed soft bones and muscle spasms in a set of people who had elevated calcium levels. But at that time, parathyroids were not discovered and the illness was a mystery. But in 1853, when Sir Owen came and diagnosed discovered parathyroid, then he, another one, Sandstorm, he is also a physician. He named the parathyroid glands as glandulae parathyroidae, and all these peoples had the soft bones and muscle spasm. So we gave the topic as Culpepper's curiosity. Yes, sir.
How do you explain the anemia?
Anemia, she had it a chronic anemia, sir.
We had done upper GI scopy and lower GI scopy to rule out the anemia, sir. It was normal. We are thinking it's a iron deficiency anemia. We discharged her on iron supplements.
The stage group, if a person is coming with an onset hypercalcium and anemia, you're thinking more on the lines of malignancy, right? PKH is elevated.
Yes.
Do you think all the patients with the parathyroid adenoma require surgery?
No, sir.
Do you know who requires surgery?
Symptomatic people, plus if it is causing any difficulty in their day-to-day.
Did it produce difficulty for her?
It was metabolically active, sir, but we have referred her to endocrine surgery. They told they'll follow her up on OPD basis.
Thank you.
Thank you, sir.
Anything else to ask them?
The family history in this case be important.
Yes, sir.
Right.
Malignancy can be on the
Yes, certain syndromes
Men's
which are
syndrome,
men's
she can have.
what family
Family.
history suggested about men's syndromes.
Coming next. You're from which unit? Medicine 1. Okay.